So we're going to talk this afternoon. This is something that some of my colleagues and I developed back in the late 1990s. So I'll start with a story. I was just gotten out of my fellowship when I was started back on active duty to pay back my time. You know, these are time or money in life, right? And if you're a poor guy like me, it was time. So I owed time from the Air Force Academy, I owed time for medical school and all that. So I was going to go ahead and pay my time back. And I started back in the early 90s and had a patient who came to me whose baby had trisomy 18. This baby, by amniocentesis, also had a severe abdominal wall abnormality, severe cardiac, and also I think had an intracranial abnormality. So this child's life expectancy was going to be limited. At that time, there was no program or anything for the care of that patient. So when they came to me, being particularly pro-life, we decided we would just take care of the family and we'd do things. The time came for delivery, and of course, at that time, when in the military, we really didn't like family members to come in, especially children. They had a couple children. One I think was about 8 or 9. The daughter was about 6 or 7. And so we decided that we would let them come in and be a part of the delivery or shortly thereafter. And we delivered this little Jonathan, and it was about 37 weeks. He was a little bit preterm, but not much. And Jonathan delivered, and then Jonathan got to have his brother and his sister and his mother and father and the grandparents all hold Jonathan for his whole life, which is probably about 25 or 30 minutes. And I thought, wow, that's just really the way we ought to do this. And I'm wondering why nobody ever talked about that or did it before. That's because nobody really wanted to do that or be involved in it, I guess. I call it sort of a God thing. So we're going to talk a little bit about that going forward about how this sort of has taken almost a life of its own. I like to show pictures of my family when I get a chance. Last time I didn't have enough time. That's my lovely first wife, Catherine, on the left. She's my only wife, but she's also my first wife. Everybody always says, why do you say that? Well, you are my first wife. That's my daughter. That's Mercy. That's my youngest, oldest daughter now. That's Penelope, who's she's actually my grandchild, but she's not my child, so she's 7. And we're there in, if you can guess where this is. Where is this? Yeah, we're in Florence. Yep, that's the Duomo behind us there. Yeah, went on a trip and did all that. That's the other advantage of being, older. Have a little more expendable income. You can go on trips and stuff. Plus, they paid my way again, so it's nice. Exactly. It's always better when they pay your way. So for those of you who are very German like my wife, very Ordnung, we'll give you the outline of where we're going to go and what we're going to do so you don't feel like I haven't told you sort of what we're going to do. We're going to talk a little bit, introduction sort of. We'll talk about patients and families. We'll talk a little bit about background, talk about birthing plans and some things we can do to help, keepsakes, other things that we talk about, celebrating life. And the resources I put way at the back, what I'll do is, like I told Ms. Jackie, I'll take these and give them to her so they can be available for people to have, because there's a ton of resources I have in this that I'm not going to put up on the screen at this point. So basically we're going to talk about, it's called them terminally, but they're children with actually limited lifespan, and how to create birthing plans and how to engage support and how to do this and have resources to put together for the perinatal hospice, as I call it. Well, the previous options that were always talked about and the things I was taught when I was a resident and a fellow was that, we would just do terminations of pregnancies, which I wouldn't do, but that was because we would do that and that the families then could just get over this and that we would do something, because obstetricians are surgeons, really, so we like to do things. We don't like to not do things. We also thought we were going to avoid maternal complications of pregnancy and of childbirth, and we thought there would be people dying all over the place, like it's always told when you talk about this stuff, right? People are going to be dying everywhere by the millions, right? There were tens of thousands of women dying by abortion in my country, and the actual fact was, 23 in 1972? Yeah, thousands, gabillions, yeah. And there we are in Florence. There's the Duomo, and it was kind of rainy and cloudy, which was good because, Venice can be a little bit fetid in the hot summer, if you know what I mean. Yeah, it is, after all, swamp. Well, what about grief after termination? And I sort of did a lot of this, and this actually shows up in a couple different places in different ways. They did a case study control actually in Denmark, where they looked at 23 women who terminated for anomalies and looked at people that actually had stillbirths, basically. And they thought that initially the grief responses were fairly similar, but when you looked at the termination pregnancy group, after 2 months, they had a major depression rates were quite high, actually, and that actually 22% actually sought psychiatric counseling in the termination group, not in the stillbirth group. There's another study done in the Netherlands where they looked at 147 women that had terminations. You got to love the Germans and the Scandinavians. They keep really good records. The Finns especially too, and the Danes and the Dutch. So what they looked at, well, maybe it's just 2 months is too early. Maybe if we look at it longer, people do better. Well, they looked at actually outcomes at 4 months, 8 months, and 16 months, and they found at 4 months, people who terminated for anomalies revealed pathological levels of post-traumatic stress, meaning that they weren't functioning. Hearing babies crying, crying all the time, could not function in daily living. So there was something going on there. And at 16 months, about 21% were still having symptoms. So something is happening here, and it's not, people just don't get over it, really. They did another one looking at 253 women again in the Netherlands, which is a different group of women, not the 147, but a different group of women at 2 to 7 years. Well, maybe if we wait even longer, it'll be better. What they found is that they still had a relatively high percent of grief, but they still had a 17% post-traumatic stress rate. So that's very, very significant. You're not picking me up?
The longest peak of the whole.
I'm too tall? Is that what it is?
Too tall.
Too tall? Okay, sorry about that. There's a problem with being vertically challenged, isn't it? Yeah. Sorry. So what they then did was another study that was done by Janssen, again in the Danish literature and Dutch literature, was they said, let's look at women who have first trimester losses with women who have live births and see if maybe if it's just miscarriages, just having a loss. Not a termination, just a loss. Let's look at that and sort of see if we can look at it. It's not exactly the same thing, but it's fairly similar. It's hard to get a large group of stillbirths together. In fact, if you try to find 220 stillbirths in a population, it's very difficult because stillbirth rates are actually quite low, in spite of what people think. So they said, okay, let's look at what happens if you have a loss of a pregnancy with a baby with the heart tones in a first trimester, which is a loss and is very, very difficult for women. Well, at 6 months, there was an increased risk of depression and anxiety and somatization. That is, you have physical symptoms. But by 1 year, women who've had a miscarriage, not a termination, a miscarriage, and a live birth are pretty much the same in terms of their mental health. So there's something different about terminations of pregnancies, right? There's something completely different, and you just don't get over it. Well, another study was then done. They said, well, maybe you're just, Dr. Calhoun blowing smoke as usual. So there was another study done, and this was actually published by a group out of Harvard, as I recall. And they looked at 158 women with their partners, and they used 3 different grief scales, looking at outcomes for the pregnancies with anencephaly that did sort of hospice type care versus termination of pregnancies, and they were fairly evenly split. What they found was that women who chose to carry their child, less despair, less avoidance, and decreased levels of depression compared to women of those who decided to terminate their pregnancies, and the male data was a bit mixed. It really wasn't statistically significant. There were some trends toward less of these things, but it wasn't statistically significant. So there was a little difference with the men. They still had increased risk, but it wasn't statistically significant. So I can't use that as a statistical finding. Well, the other interesting thing in this world and land of choice, right? We all want choices. Everybody should get a choice. If you look at it, and this study has never been replicated because they don't want to, right? They don't like the results. If you don't like the results, just don't do the study. So 20% of women in that time frame, which was actually 1984-97, looking at anomalies, and this is the United States, found that 20% of patients, no matter what the findings were for the child, anencephaly, a trisomy 18 with significant anomalies that were really life-limiting, would want to continue their pregnancy no matter what. Now that's 20%. So my response is always to my colleagues, I said, well, it really doesn't matter what you want. Aren't you all about autonomy and patient-informed consent and about giving people choices? Then you need to give them a choice, right? If you have a hammer, everything's a nail, right? Right? If that's the only tool you have in your toolbox, then everything's a nail. You can't fix things without the right tool. You can't beat something with nothing. Just, go away and let me take care of you. Don't come back if you aren't going to terminate, which I've heard from multiple women, by the way, from their doctor, which just astounds me, but not really. It astounds me. So what can you do? We're also going to look, mortality risks are not increased. If you look at the risk for abortions at 16 to 20 to 22 weeks, The rates of mortality are approximately similar as it is for maternal mortality at term, even though they keep saying the maternal mortality is going up. In our country, they said it's 21 or 22. Maybe, maybe not. Again, it depends on how you count it, how you do it, what you include. So again, you got to be a little bit sort of skeptical sometimes. So what is perinatal hospice? After the background talking about we're not going to have increased losses, we may have, I think, better psychological outcomes in my opinion, and I think the literature supports that. It's the prenatal diagnosis of a terminally ill or a child with a limited lifespan in utero, leading to the perinatal hospice as part of the continuum of end-of-life care. So hospice principles being moved before you're born. Okay? If it's okay to do it after you're born, it's okay to do it before you're born. You see the Machiavellian part of this, don't you? Yes. Anybody here read Machiavelli besides me? Yeah, need to read Machiavelli if you get a chance. The Prince, it's not very thick. So what's the problem? I mean, I always tell people I'm very pragmatic in what I do. If there's an issue out there, do I really need to know about it and why? And is it going to be something that's going to impact what I do? Well, in the United States, and particularly all over the world, lethal anomalies still are one of the leading causes of neonatal death, really probably behind prematurity. I mean, it's one of those things, if you look at prematurity and neonatal losses, it's either anomalies or it's actually prematurity. So in our country, in my country, it's 6,000 to 10,000 a year. It's probably several thousand here in Canada. Worldwide, it's probably hundreds of thousands, plus or minus, depending on how many births there are. So because there's a lot of these babies out there and you see a lot of them, that's the reason why I'm interested. And usually if I talk to somebody, almost everybody here knows somebody who's had a baby who they've had either a child with a trisomy or an anencephaly or some sort of serious anomaly of some sort or life-limiting diagnosis. Almost everybody has somebody they know or knows somebody who knows, 1 or 2 degrees removed, right? So always the diagnosis has to be correct. Most of my life is spent telling people that whatever somebody else told them is not there, all right? Because they see things they think are there and they aren't, which is okay. That's my job, is to do that. So a lot of my job is to do that. So make sure your diagnosis is correct. Most people fear abandonment. If you look at the hospice literature, the reason the hospices were developed was because people were abandoning people. They weren't dead yet, but they treated them if they were. Right? So abandonment is a huge thing for patients who have children who have significant medical issues. I use non-medical terms and be clear. You don't tell the patient, oh, your baby has anencephaly. Say, I'm sorry that part of your baby's cranium and brain seems to be missing here, and try to show the picture of what you're talking about, try to help them understand. And I always tell them, I said, please don't go out on the website and look at these things if you're not really right away. Please don't do that. That's not a good idea. Just go out and look at anencephalic babies. That's not really going to help you. I discuss hospice with all my patients. We're very clear in the United States, you have to tell people they have the legal opportunity, which of course makes no sense to me. They already know that. They can legally go do an abortion whenever they want in the United States, right? They can do that anytime, for whatever reason they want. So I make sure that's clear on that if they want to, but that's not what we're going to talk about. And once we're done talking about that, then we go on and talk about hospice. I have my residents, my nurses on labor and delivery, my sonographers. I have social services that gets involved because many of my patients are very poor. They need help to get transportation. They need help to get to appointments. They need help to figure out how to deal with lives, other children. We talk with family members if we need to. I always have had chaplains or priests or rabbis who are willing to help me, and so that's always good if they're people of faith to have them involved as well. And that this is not really a passive process, that you're going to be actively doing a number of things when we talk about doing hospice. So it's not doing anything, it's doing the things we can do to help the families move along through this process. That's my daughter, Faith. Faith had a metabolic disorder. We're not sure what it was, but it involved carnitine. Maybe it was glycine. Where's Dr. Brand? Maybe not. Maybe it was glycine. You still at lunch because it took about an hour? Yeah. So maybe it was glycine, probably not. But we thought it was carnitine since she got carnitine and some other things, and she was prone to acidosis. Faith required full care. Faith said she was going to die every 10 minutes after she was born. I mean, we got her as a newborn, and she was going to die in 3 weeks. She was going to die in a week. She was going to die in a year. She's going to die, blah, 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 blah. The usual omniscient doctor telling you what's going to happen. But of course, she lived to almost 28. So that was the whole thing, is that as you go on through life, you understand that you think that she's just going to keep going on. Well, eventually, and she had a heart defect as well because of her genetic whatever it was. But as you can see, Faith doesn't look very handicapped, does she? Now, she's in a chair, but she's not handicapped. And you can see she's got that look in her eye like, I'd really like to ram you with my chair. Yeah. And she would. The person in the room who would ignore Faith was the person she would pick on to go see. Truly, always, truly. So we're going to talk a little bit about some of the things we do for dealing with all this. And they talk about emotional, physical, social, and spiritual. And I think it's really important to understand that you have to build a really good team. And the good thing about this whole hospice idea is that you break down a lot of stovepipes. You get nursing involved, you get anesthesia involved, you get your neonatologists involved, who I didn't talk about, but my neonatologists are important because talking about helping, what are you going to do for resuscitation, what are you going to do for feeding, what are you going to do for oxygen, what are you going to do for pain relief if you think you need to have it, are you going to do some minor surgical procedures if we need to, how are we going to handle all this, and what does that look like for my family? Okay? Because it's all about them. I hate to disabuse most of my young colleagues, but it's really not about you, I know they find that just reprehensible I say that. It's not really about you. It's really about your patient. So get over yourself, right? Yeah, really, truly. Yeah, it's not really about you. I know you think it is, but it's not. This is my daughter, Mercy, at 18 weeks. The one you saw that was almost 22 or 23, that's her doing the old thumbs up kind of thing there. I think it's very entertaining because that is really a bad picture. Now I got you can see the kid's faces, the eyes and eyeballs, all sorts of stuff. It's completely different now in 3D, right? So we look at a lot of things, and part of this is going through, like we talked about some of the Kubler-Ross's phases of grieving, and talking about the stages of grief, and about the whole idea of how you deal and go through this. And it's really interesting that if you look at a lot of these things, the anger, the guilt, the irritability, depression, the isolation, all this stuff, really a lot of this stuff is isolationist, right? You're isolated from others. Because it's really hard for someone to say, I really understand what's going on here. I know I've got my 4 healthy children and my happy marriage, and I'm really doing well and all this stuff, but I understand about your child having a lethal anomaly, right? No, I mean, really, it's really very you want to be empathetic, but it's truly isolating for people who have a child who has a life-limiting anomaly. That's why I think God was so good to give me a child who had this thing with her life, because I could truly understand. I have walked that trail. I walked the trail for her being in an intensive care unit for 3 months. I walked through all the life of taking care of her. I walked through the valley of the shadows of death with her. I understand that at a very personal level. And I really encourage people to find others if they can, and we try to refer them to people who've had similar experiences, because the isolation here is what you're seeing, right? It's the isolation. And it doesn't mean you talk, it means you just are there, right? You're just available. And these patients get a lot of visits in my unit, and everybody says, well, do you get paid for it? I said, I don't really care, right? There's plenty of money. There's plenty of money. I don't care. The hospital wants money. I don't care. That's their problem, not mine. I'm really not going to, I'll just write it off. I don't care what we do. It's not, I have plenty of money. There's plenty of money to do this. And everybody keeps getting all wrapped around the axle about that, but that's not the question, is it? So there's all the things that go on with this that you have to help people work through. There is the sleeplessness, there's the depression of sleeping too much, there's the headaches, there's all the things that are going on with people that have these particular things. And so as the physician and the people who help with this, you have to understand when they start talking about things that are going on, they're all related probably to the fact we're trying to work through this grief, this loss of what you believe your expectations are for this child. And so what part of the help is to try to give people what their expectations might be and what they might be able to do. Amy Kubelbeck talks about how this allows parents to be parents, the hospice. And I think that's the most wonderful thing to say. And I also say that when we talk about all this, we talk about a life well lived, we talk about quality of life, which I love. I like that. You're going to tell me what my quality of life should be. You're going to give me little numbers, right? My qual factor, right? Yeah. Really? You can't make this stuff up. I mean, really? There's your qual factor. I said to them, well, what would you say if every moment of your life, however that would be, brief that would be, that you were loved and held and had people who loved you with you for every moment of that life, would that not be a life well lived? And Jonathan had that for the 30 brief minutes he lived. The children I have who live for a few hours or a few days have that. There's always their family there, the ones that have very life-limiting. So that's a life well lived. And that's the expectation you start talking to people about what they can expect and what they can participate in, what they can provide for their family and this child. Because that's not nothing. That's not nothing. And they can then start working through these stages. That's Penelope making chocolate in Venice. That was actually pretty fun because it took about 2 or 3 hours and we were making it. And then we got to take them home and eat them. And of course, that was the best part of all, right? Yeah. Oh, yeah. So again, the whole idea, isolation, avoidance, abandonment, argumentative and irritable, all these things are the whole idea of socially that people that are having these babies who have these life-limiting diagnoses. And so the best thing you can do is to, even in spite of the fact that they may not want you around, is be around or be available. Okay, that's the biggest thing. Every study done on hospice, everyone fears isolation, everyone fears abandonment. That's what they fear. They don't want to be left isolated and out of social contact with people because that's the hardest part of all this. It doesn't mean be intrusive, it just means you have to understand this is what they're going to feel and want to think they want, but they really need just people to be there. And understand if they, rip on you, well, that's because they really need to talk to somebody and they're just not having a very good day, right? Anger towards God, very common. Anytime there's a major thing in life, it's, well, why did God do this and why not? And I always tell people, well, I know why he did it. He did it for his glory. How that works out in the eternal scheme of things, I don't know that answer. That's up to God. I know why, but I don't know how that all works out into the whole deal, right? I don't know how that works. That's why I encourage them to talk to the chaplains. I encourage them to talk to their pastors or their deacons or their bishop or whoever else they need to talk to, their rabbis or whoever their spiritual person is to help them understand in the context of their faith and their belief system of what to do. And shockingly enough, I know this is going to sound almost blasphemous at this day and age, but I will pray with my patients if they would so desire, and I'll ask them if they would like me to pray with them. But I always ask permission. And it's really funny? Never have I ever been turned down. In 30 plus years, no one's ever said, no, I really don't want you to pray for me. Nah, I don't believe in that God stuff. Nah, I'm not going to do that. Don't pray for me. Never, not once. Now, it may happen sometime, but it never has so far, ever. Now, there's Penelope's now making pasta in Tuscany. I would hardly recommend it. The best part about this, of course, is while they're doing that, I'm drinking the wine. Well, somebody has to do the quality control. You know what I'm saying? Yeah. And then we got to eat all this. It was fabulous. Hardly recommend get a chance to go out and make food with your children, your grandchildren. A lot of fun. So we're talking about ladies, sort of the ladies' side of this to start with. Basically a lot of tears, which makes those of us who are men, at least men of my age and my training and predisposition, uncomfortable, right? I don't like that. Really, daughter cries, it's like, oh, here we go. Oh, you're cheating. It's not fair. Stop that. Yeah. But you're going to see that, and that's okay. You need to respect the need to share and communicate, and talking it out a lot. Of course, like my wife, is a way to help her process. It's taken me probably almost 40 years. I know that's a long time, but men are stupid. She doesn't want me to fix it, right? Men are fixers. We heard that. Men are fixers. She wants me to listen. And just listen. And that's hard because I don't really want to listen. I want to fix it, right? Yeah, no, really. Being honest. Accept and respect the need for social support. So family members need to stay involved, but not be intrusive. And again, that's that fine line we always walk when we have these issues. Accept and respect the focus and investment of this in the past time frame in relationships. Helps links to the loss. So good strong family and church relationships are very important here and help with this whole process of grieving and understanding what's going on, what's going to happen. Guys usually don't cry very much. I mean, at least in my generation, that's just what it didn't happen. Didn't talk a lot about this stuff. We don't talk about feelings. My wife, she'll want to talk about feelings. I go, no, you're not reading Red Book again, are you? Please stop doing that. I don't want to talk about, really, I don't like talking about feelings. I'll be honest, really, I don't. And my wife gets very upset with me about that. I go, but that's just it's a guy thing for me, okay? Problem solving, I want to solve it. We can't solve this. Accept and respect the need for alone time. So sometimes, a guy just needs to go out and do something outside, chop wood, do something just to go outside because that's what he needs to do. And then focus energy on the future rather than the past. One of the most poignant things I ever saw, and actually Amy talks about this in her book, what she has, it's called The Gift of Time, I think is what it's called, where the father of the baby was a woodworking gentleman. And his way of dealing with this was he made the child's coffin for his child who he knew was going to have a life limiting. And I always thought, that's how he worked through his grief and how he worked through his sorrow at this unrealized expectation of this child that he had so many hopes and dreams for. So the one thing he could do to help fulfill that was to give his child this place for a child to be buried in, the coffin. So I always thought that was a very moving story. Still much chokes me up, actually. It's difficult to share with patients' family members, and sometimes I help with that, sometimes others do. I usually don't share stuff because of multiple reasons. It's part of it's the Hippocratic Oath, which I did take. And part of it's because you're not supposed to do that. It's against the law. Actually, you can't share patient information, that sort of thing, right? And sometimes family members are upset with you because you're telling them they're going to carry this baby who's going to have an early loss or a limited life, and they don't understand about why you're doing that, why are you tormenting them, why you're doing this, and you're trying to explain because it's better if you don't do the termination than if you do the termination. Don't do that because we know that doesn't go well. No matter what people say, that's really not a good idea. Really not. Always ask the questions. I allow the family members if they want to be in there. I also break one of my cardinal rules is I don't do video because it's not entertainment. Okay, I don't do video at ultrasound. It's not entertainment, it's a diagnosis. So, but I do video for patients who have children like this because sometimes this may be the only video they have of their child that while it's alive, because in some of these 30 or 40% are stillborns. They're not born alive. So I give them the video so they can have memories of their child alive and can share those with their family if they would like to do so. I also stress family support is critically important to this, really, and that we're not going to harm mom. Mom's not going to die, quote unquote. Remember all the TV stuff? I don't know, in the state shirt, all that stuff. I was going to die if I didn't have my baby aborted for gastroschisis. Remember that deal? I'm looking at him and go, gastroschisis? I mean, that's just bowel outside the abdomen. That's totally fixable. What are you talking about? I understand what you're talking about. Why would you do that? Or my baby had a cleft lip or palate, so I was going to die if I didn't. What? Or clubfoot. What? What are you talking about? I mean, those are totally fixable. There's nothing wrong with that. You're something wrong with your head. Really? So let them know that you're not going to put their partner, their wife, their daughter at risk because you're going to take care of them. In fact, if you look at the data for abortions as you get farther along, the risk for death goes up after 22 or 23 weeks abortion compared to a delivery, about triple, okay, or quadruple. So you're actually doing the right thing. This is my wife, and Mercy and Penelope, and I love Pompeii. Anybody Pompeii? I love Pompeii because I love it makes me think of in a way about hospice, about how if you organize things the proper way, things actually work out better. So if you build the road so the carts can go down the road like they're supposed to, it actually works better than if you don't. If you build a system so that people can navigate through how to work through this problem that they have with their child, quote unquote, or this child has a limited lifespan, it works better than if you just throw them under the bus, right? You give them tools and support them in how they can do this. That makes it better for them and that makes it work well. So it's not quite like engineering, but it breaks down all those barriers. I like creating birthing plans. I know that every obstetrician shudders when they hear this because every time you hear birthing plan, you think, oh, here comes a C-section, right? Yeah. And the bigger the birthing plan, the more likely to get a C-section. We kind of laugh about that, but that's not quite true like that. But written guidelines are very important, and I'll tell you why. That way, the patient's wishes are carried out. The other thing it does is it helps the patients and their families and the doctors all get together and make sure they're all doing what everybody in the family wants. And we're all sure that we have the same thing. So if they want to do fetal monitoring of the baby, we're going to do fetal monitoring. If they want to have the neonatologist give oxygen and resuscitate, we're going to do oxygen and resuscitate. If it happens at 2 o'clock in the morning when I'm not on call, the doctor who's on call will have the written guidelines so it doesn't get co-opted, right? It doesn't get off the rails. It also makes us think about what we would like to see happen, right? And that makes it more real, and that makes it better for the families so they're able to organize it. And I also tell them, make sure you have a copy of it. Make sure I put a copy in the chart, which I always do. And I always make sure that there's a chart copy that goes to the hospital. So that way there's 3 different copies so that we all know what's going on. And I also make sure they get a consult with my neonatologist so they know what's going to happen too. And a consult so it's in the chart as well so they all know what the plan is, right? Because you don't want the plan to get, like I said, it's invariably 3 o'clock in the morning and it just gets off, it goes way where you don't want it to go. So we talk about types of delivery, we talk about anesthesia, we talk about fetal monitoring, I talk about attendants and visitors. Again, there's a rule of only so many people back in the back with deliveries. That's one of the ones we kind of, sort of like Pirates of the Caribbean, it's more like guidelines. Not rules, not really rules. Yeah, more like guidelines, yeah. More like guidelines. So we'll let children back, because usually you don't let children under 12 in labor and delivery very often. I mean, that's just one of them. But we have some rooms that are off where we can do that, so we try to do that as well. So again, a lot of this is just really figuring out how to work with the group you're with so they give the patients what they really need and want for their child and for their family. Are siblings involved? I always encourage that. If they feel like their children are mature, let them make that decision and say it's okay, we'll figure out a way to do that, right, and involve your children. Medical interventions, comfort care with the neonatologist, critically important. If they want a baptism, a dedication, or a blessing, who's going to do that? How will you notify them? It's critically important that they have a live birth. Actually, everybody laughs about this. I will do primary cesarean sections for children who have a life-limiting disorder, so they can have a live baby. In other words, if somebody has a baby who has an anencephaly, and their tradition of their faith is they really want to baptize their baby alive, and they want a live baby, then I'll be glad to do a primary cesarean section for that, realizing there's risks to that and all the other things that go along with that. And everybody says, well, why would you do that? Because American College says you can do it just because you want to. If a woman comes in and says, I want a primary cesarean section, you're supposed to do it. I don't do that, but some people do. So I said, if I can do it for that just because you want to, for no real reason except you just want to, I think I can do it because somebody really wants to have a live baby and hold it and have their family hold it, and they want to baptize their child because that's critically important to them to do that. Genetic testing, we always recommend that if we have not gotten genetic testing, we do that. If people allow us to do autopsies, I like to do autopsies because on ultrasound, again, I've told you before, it's black and white and gray. There's things you don't see. It'd be very nice to get that extra data if they will let you do that because it may change your diagnosis in up to 20 to 25% of cases. So it's really important to get that information if you can, and they will allow you. Memorial services and plans, that's critically important to the patients. So if there's going to be a service or a ceremony, you got to make sure that gets done too. The other thing is I tell people, and people get really kind of weird when I say this, but just don't lose the baby, right? Don't lose the baby because remember, if you're in a large place, like mine is a huge hospital and lots of stuff going on, make sure you have protocols in place so the moms have the babies and you're going to keep the baby there, that baby goes to the right place. It doesn't go to pathology. Because if your baby goes to pathology, it goes to pathology, which means it goes away. It doesn't go to the funeral home. And that's happened before in other places, so be very careful about that as well. Keepsakes. Does anybody know where this is? Tivoli Fountain, right, in Rome. Yeah, Trevi Fountain. Let's see. So keepsakes. We do a lot of that. And I'm a big person about keepsakes. I think visuals and palpables are critically important. I'm a visual, but I'm also a hands-on learner, which is why when I do stuff, I write it down because that's how I learned. I'm old. I learned to write it. So if I write it down, it becomes real and I learn it better and I can remember it. That's why I tell people, that's why handprints, footprints, locks of hair, blankets, photographs, the baby's, maybe the clip on the baby's umbilical cord. All these things are critically important as signposts for people to remember their child with, and to remember the name of their child with and keep with. And we have these beautiful toolboxes we do now. My patients do. My people do a wonderful job. Has anybody heard of Now I Lay Me Down to Sleep? Yeah. if you get a chance to go on their website ever, they have volunteer photographers who are professionals that do the most beautiful, both before delivery and after delivery photography, black and white, and a lot of it just absolutely beautiful, and they donate it. So we try to involve them if possible, and then we have a digital camera. We take all the pictures that they'll let us, as many as the patients want, and then we have those available if they want them. If they don't, then we, like after about 6 months or a year, we usually delete them, but we have them available if they want them. Because some people don't want pictures initially, some people do. So birthing plan, short, make sure you have your name and physician, typed please, handwritten is always hard to read. Flexibility, put in your memory-making desires like footprints and all the other things, and have several. And I always tell people, make sure you bring one to the hospital with you. Make sure you bring one. There's all sorts of places you get birth plans from. I have a couple that I do. There's a whole bunch of that do a lot of them. The best website is actually perinatalhospice.org, www.perinatalhospice.org. And that's Amy Kuhlbeck's website, and that has all sorts of resources on it. That's probably the best overall website. There's Kathy with Faith. Yeah, she's such a stinker. Whew. What about checklists? Okay, I always tell people, what should I bring? I said, well, here's what you should bring. If you're the lady or the dad bringing this stuff, make sure you bring your birthing plan, your health stuff, a journal so you can write your journaling if you want, comfortable gowns and robes and slippers, underthings, glasses, contacts, anything you need for your hair. Change for vending machines if you have them in the area. For the baby, clothing, 3 or 4 sets perhaps, receiving blankets if you want it, booties, socks, hair bows, bath soap and powder if you want to because you'll be able to bathe the baby, comb and a brush, even a pacifier because these babies live, many of them, several hours, and this is good to have with you. Calling cards if you don't have them, bring your cell phone, all that sort of stuff, books, magazines, toiletries, all the stuff you might want to have while you're there. Camcorder, make sure the camera has either a SIM card in it or actually is working, right? Been there, done that. On a trip. Oops, the batteries are dead. Yeah. A baby book, all these things that you want to do that you might want to take with you. Pre-register at the hospital, I tell that to everybody. Make sure you know where you're going because sometimes big hospitals, mine's not that big, it's big enough, don't know where they're going. Private tour of labor and delivery, I encourage this for 2 reasons. One, they get to meet the nurses and they get to see the people, and a lot of my nurses, I have somebody pretty much on every shift who does the grieving, who does the hospice, so they get to meet at least one person they know who's done that. We do private childbirth education, we do that, and we have all private rooms now, so that's not a big issue anymore. And we do have a room that actually has, it's a double door, so they can actually be away down the hall, and then there's another door and a waiting area, their own waiting area, so it actually works very well for us. There she is. I'm going to throw stuff in there. She keeps saying she wants to go back to Italy. I said, well, maybe. What about other things? Important numbers to take with your names and numbers and notes, and I really do tell people to get a journal and start doing things for their, I tell them to start right away, actually. I tell them as soon as we make a diagnosis, you might want to do this. I've had people do written, I've had people do verbal, I've had people do video, I've had people do all sorts of things for immortalizing the pregnancy to help them remember and help them work through this process, but also to bring it so you can have ideas for birthing plans and things you might want to consider to do. That's my son, Dan. That's Penelope's dad. That is a 500-pound boar. Hard to believe he got that, but I'd show you mine, but it looks like a tiny baby shoat pig. I'm not gonna. I'm having boar envy. Yeah, this is actually up in Michigan, up on the Upper Peninsula, with the Upers up there. Yeah, it was a good time. Name, doctor, due date, brief story. Use the baby's name, and I encourage my people ask for the baby's name, and use the baby's name. Not it, whatever. Just try to get that so that it becomes more personal. I try to do that anyway, but I mean, particularly in these patients. We talked about anesthesia, monitoring, privacy, all these things we talked about. That's Mercy at 18. Now, she's a little bit nicer than that. Ultrasound, yeah. That's the glamour shot, right? That's because she's an artiste. She's a diva. She's a singer. She had to have her glamour shot, right? So other things, pre-birth announcements if you want to do it, birth announcements, blogging, scrapbooking, photographs. I already talked about not letting me down to sleep, slideshows, jewelry. ultrasounds, DVD, all the things you might want to do, recordings of heartbeat, which we allow, pictures, footprints, bracelets, engravings, molds, cards, all this stuff that you want to have, that patients want to have for memorializing the birth and life of their child. They need to have a list in their mind and make sure. We usually ask for all this stuff. We really do. My people are very, very good. There's Paul. That's Paul, my son. He's the Army guy, right? And that's Barb. Spiritual care. I really recommend using all your spiritual people you can, your chaplains, your rabbis, your pastors, anybody who's their people of faith. There's support groups online. I have patients who have delivered children in my area, either anencephaly, trisomies with limited life, children with serious life-limiting things, and I try to connect them with the patients if they want. There's also pretty much a blog almost for every one of these, and again, the www.perinatalhospice.org has a lot of those connections. I have nursing personnel. I have social services are really good, and then we have a grief group in our system where they get together and they'll share. It's like a bereavement group, and they'll do that. That's about once a month or so. Anybody know where this is? No. Close. It would be in Portugal. Fatima. It's Fatima, yeah. I went to Portugal too once. Got invited to go speak there. This is the great thing about being Irish. You get to these people, you're loquacious, they want you to talk, pay your way. Yeah. But this was at sunset. It was really quite impressive. It really doesn't give you the whole idea that it's just kind of this ethereal thing that's coming off off that white stone. It was really beautiful. Hardly recommend if you get a chance to go to Fatima. I've not been to Lourdes yet. I'd like to go there eventually. But I don't think French will have me, so that's okay. So really, the whole thing about this is to celebrate life. We've talked a lot about that. And I always talk to people that, when you talk about hospice, I always ask, is anybody going to get out of life alive? No. It's not a matter of if, it's a matter of when, isn't it? So I talk about celebrating life, a service, and I often try to attend if I can with my families if I'm able to, using lullabies, using music, encouraging stories of birth and pregnancy, allowing people to share, celebrating life at this memorial service or this I call it celebration of life service. I really don't think of it as a funeral. I think of it as a celebration of life. At least that's why I would think of it. And we did that with my daughter. We did all that. And a registry for a memory of those who attended. So that's really what we're talking about when we're talking about hospice. We're talking about celebrating the life of this child, this family, and helping them and encourage them along, which seems to me to be a way better way of thinking about this and doing this than to tell people to go terminate your pregnancy, pretend like it didn't happen, and get over it, right? Because you don't get over it. It doesn't work that way. It doesn't work that way. Great books. Waiting with Gabriel by Amy Kubelbeck. Probably one of the best ones ever written. Very, very good. There's a couple other ones, Holding On to Hope, and then A Guide for Fathers by Tim Nelson. A Gift of Time is the other one that Amy wrote, which is about different stories of people at hospice, and she has that available as well. So Amy Kubelbeck's got a really, really good book she writes. And the reason I put this in here, this is a real ad. from the 1950s. I think it came from Look magazine. I can't put that in there because I'd probably get sued. But remember back in the 50s, doctors said that, cigarettes didn't cause or be associated with cancer, right? So they can't be wrong. So I always put that in there and say, just go terminate your pregnancy. That's what the doctors say to do. Safer is better, whatever. Well, that's probably not right because doctors are often wrong. Often wrong. Any comments or questions? That's my email. You can try to give me if you'd like. And I'll put these slides. I'll give them to you, Miss Jackie. We can have the slides. They won't give you the family pictures, but I'll give you everything else, right? And I've got a ton of resources at the end of this. I've got all sorts of books and other things that'll be useful if you're interested. Questions? No? Yeah. Yes? They've got several, and actually I didn't put those on I usually put those on a list. I think there's one actually here in Ontario. I think there's one in Quebec, and I'm trying to think there's one in BC, I think. But if you go on Amy's website and you go to country, look at the countries, it'll pop you to Canada, and you can find out the list that there. And it changes weekly. Seriously, I mean, there's hot. This started out with an idea. One hospice when I was in Washington State. There's now over 260 I know of in the United States, and there's over 300 and some odd now in the world. Almost every country and almost every area has some hospice or is developing a hospice, perinatal hospice or hospice type work. So it's very gratifying to see this continue to grow. Other questions? No? You're stunned. Okay, well, that's all right. All right. Thank you.